Good afternoon, everybody. So, as we have told before, only that this month we are going to discuss only about stress urinary incontinence, and indeed, we have discussed a lot of cases this month related to various combinations and permutations of stress incontinence with fibroids, with prolapse, simple SUI without, and many with comorbidities also, and other urinary complaints. We have also posted 2 surgeries which we usually do. So, as I hope all of you know, that tension-free vaginal taping is the surgical gold standard for treatment of SUI, and there are 2 approaches: retropubic approach and obturator approach. We have shown both of them in different videos this month. Now I was thinking that a lot of theoretical we have discussed. Okay, this, even if we do not tell you this, you can go and see it in your textbooks and attend a lecture and do that. What I feel to end this month, the best thing will be to share our experiences with you. And we have named this session as Experience Chat. And for that experience chat, I had with me Dr. Preetha, who is our dedicated physiotherapist who works with us in our Urogynecology clinic, and Dr. Sreelakshmi, who is a clinical psychologist. All 3 of us are working together for last 3-4 years in a clinic, and we can see the kind of improvement. Why I wanted to do this session so desperately is that you can never achieve those goals which you can achieve as a team. So today we will just discuss. We are not going to teach you anything. Okay, we are just going to discuss how our experiences. So we'll tell you how we have grown while treating patients with stress incontinence. So I'll start my story. So what happened when I was a postgraduate student for 3 years? To tell you the truth, I had never seen a single case of stress urinary incontinence in my life. I never saw a patient who actually reported an SUI, or even me or my seniors or my juniors or my teachers asked them whether you have SUI or not. I never saw a patient. Okay, but it was an important question for theory. So I remember we all friends, we used to discuss, mark it up, okay, this is the test and how it is elicited. Just imaginary, because when you don't see a patient, it is too difficult to remember those things and replicate those things in exam. So it was a big topic for us. We sat together, remembered it throughout the night. So very difficult it was. I cannot say when this turning point came. Even when I was working as a junior consultant, I do not remember seeing many patients as SUI. But I cannot say, maybe in 2009 or 10 this thing came and I started seeing patients. Somebody showed me SUI, okay, when you demonstrate, this is the way SUI patient presents, or maybe patients came. And now in, I think, 15 years or so, the things have changed so much that when it's really what is written in the books, we see that after certain age or after childbearing, every second or third lady is having some grade of SUI. Not everybody will have severe SUI, but everybody will have second or third women will complain of. If you ask, they will say, yes, we are having this problem, but maybe they are thinking it is normal. So how have your experience been, Preetha? We'll start with Preetha.
Yes.
In SUI, yes, your understanding.
Yeah. So as a women's health physiotherapist, we have, we see patients across the various age groups, I would say, adolescents, then we have in pregnancy, infertility, pregnancy, postpartum, gynec, like that. So usually the patients who come to us are either pregnant women who do not even know that this is a part of,
they come for antenatal exercises.
Yes.
They don't come for SUI.
Exactly. Yes. And then we ask them, we ask them, do you have any complaints? Generally we ask, and it just never come out of their mouth, actually speaking. But when we ask, do you leak when you laugh, or when you say lift any weights, or when you get up from the bed or something? Yes, but that's a part of pregnancy. That's how they usually have taken it up. Same thing as after during their immediate postpartum, or say 2-3 years after childbirth. Again, we have patients who come with some difficulty, or when we ask them, they tell us about it. But again, next set of patients are between 40 to 50 years, when they have a lot of, I would say, stress, because they are either caretakers, either children they need to take care, or elders at home. So a lot of work is involved, bending, lifting, all that. And you have an age group of women who come, nearing their menopause or postmenopausal women. So these are the set of or categories of women who have actually approached or have been referred for physiotherapy, or have sought help as such. But everywhere, when we started noticing them very close, that's something that we have noticed, that they have some other weaknesses that is associated with it. For example, abdominal muscle weakness, or there is obesity, or they are not doing the activities the way they are supposed to be doing. And we try to relate or link, because for us also, when we read the books, it is like only Kegels, that's it, Kegels exercises, how you need to do, that's all. In physiotherapy also, we just need in UG, at least in UG curriculum, we only know about that. And we are not allowed to do any examination at that point of time. So for that reason, we just learned this. But then when we actually see a patient, and when they approach, and when we know that, when we take their history and learn about them more in detail, we actually know there are various aspects around it. So sometimes I feel, Sreelakshmi can do a better job than me, because for her, stress is more than the weakness. So when we do an evaluation, muscle weakness is not a problem, but she has more amount of stress. So I feel she has a better part to do than me, kind of thing. So I feel that's the approach that is taken up.
So actually, we all are also growing together, because it is a such new branch, and everything is not written in our books. Everything has not been taught to us. So we are, I think, by seeing patient, by getting their feedbacks, by talking to each other.
That's true.
Actually, we are learning more
every day.
every day.
Patient is a learning experience, actually. Yes.
So what do you think, Sreelakshmi, regarding the psychological aspect? How much trauma this kind of patient? Because we don't even bother to ask. Like most of the gynecologists or private practitioners, when women come to them, they don't even bother to ask. Until last week, I had one patient that was seen by a gynecologist and said it's okay, like that. So then, if you do not talk to them, I think after some time they also feel very embarrassed in talking about it. So I think you are getting all those kind of patients who have suffered this embarrassment and have become silent kind of things. So what has been your experience in SUI?
Like you both said, ma'am, even for me, when I was doing my MPhil in clinical psychology, which is a 2-year rigorous training program, when I have not seen a patient with SUI, it was when I was asked to join the team that, and when you were demonstrating that, that's when even I came to know that, oh my God, this is the problem that women are suffering from. And like you rightly said, ma'am, after that, the conversation slowly started. So since I did not know about it, I never used to ask my patients about it also. So women who are in their old age or nearing their 50s, when they especially come with OCD and obsessive cleaning is there, and cleaning of genitalia and private parts, this is an important thing I think I have missed out asking them. Because when they say that I go to washroom, I pass urine, and then the cleaning starts then from there. So, and it would have been the case that they would have had a SUI. I did not know, I did not ask about it. Now when I've started seeing patients, I have slowly started asking them, talking to them. It's like I'm able to relate with them more. I'm able to understand. So since I understand that, they feel free to talk to me about that as well, that she is getting the point. She knows what I'm talking about. So they become more comfortable talking to us. And because our trainees also slowly have started posting here, they have started inquiring with the patients when they come. Even if it is when geriatric population come, this is even if they are not coming with any psychological issues per se, this is something that we ask, and it is present. Like you said, every other women whom we see, it is there. But because we do not know, we do not see and talk to them about it. And once I have joined the team, I have seen the improvement that it brings about in them, and I tell them that there is a solution for it. You don't have to suffer like that. And then get them here in physiotherapy and or your treatment. It helps, and it makes a miraculous change in their life. The quality of life improves quite a lot. Even when it comes to sexual life, for that matter, when they have coital incontinence, this is not something that we usually ask. We are people who take sexual history, we do sex therapy very often, and we get a lot of patients for that also during the training. But this is not something that we have ever inquired with them. But now I have slowly started talking to them, and many of them have those issues also. And another thing that I would like to stress here is what ma'am had told, that they would have gone and spoken about it to somebody else, but everyone has brushed it off, saying that it's a part of, you are a woman and this is a part of it and you are meant to suffer like that, which is something I think we need to break in the society. That just because you have given birth and it has brought about additional challenges, yes, but it needs to be spoken about. And the medical field has grown so much. There is treatment available for that. So people need to come out and speak about it, talk to them.
Even I think the practitioners who are practicing general gynecology, all who are the first contact, maybe
Yes.
people who are sitting at PSC or in clinics. I think 2-3 such encounters with doctors who say that it is normal,
Yes.
just puts patient in a very back foot.
Yes.
That they never, they feel like
They even
talking-
hesitate to
hesitate
tell,
yes.
if I tell this, will the doctors think that, this, and
Some
that's
people-
also is a problem for you.
Yes.
You have a bigger problem than
Yes.
is this,
Yes,
that kind of.
they're blowing things out of
Yes.
proportion, sort of, and that sort of brings about a bad name for the lady also.
Yes.
That this is a part of it. You're supposed to keep quiet about that, and you're making a big deal out of it. So they don't want that negative image also. So they're just silenced like that.
And this is like the problem, how much is it in the society? Then demonstration also, you said, Sreelakshmi, when you saw like how horrible it can
Yes,
be.
yes.
But most of the time, like in other thing, I felt that many times, like the technique, because I keep on saying this, that this problem happens when the bladder is full. So most of the times we tell the lady to empty the bladder. Many people who are checking also, they will say that patient complains of SUI, but there is no demonstrable SUI. And many a times what happens, they would have told patient to, for examination, to empty your bladder and come.
Yes.
When the bladder is empty, you cannot demonstrate this.
That's
100 times also, even if patient coughs, you cannot. So they think that patient has complained, but actually the diagnosis is not there. So the technique of demonstrating, and it is a simple test. You have to tell the patient to fill the bladder and then demonstrate, and maybe then refer a few. So many a times, patient complains, doctor sees it, examines her in empty bladder and says that no, you don't have stress incontinence. And so that also puts them off when they go back and
They don't try. It's like a doubt on the patient.
on
How
the
did she
patient,
say?
how did
Yes.
she say?
Yeah.
Yes. And the other thing that what is very important, that the like you said, that the improvement is so much. Improvement is so drastic. Like some diseases are there, chronic diseases like diabetes or like endocrinological problem or say malignancies. Patients are suffering a lot. But okay, you treat, it takes time, even in urogynecology, okay? Like if you treat urgent incontinence, it takes time to improve. But this stress urinary incontinence makes so much of change if you start exercises properly and if you tape the patient. Like morning patient will be coughing and having so much leaking within her quality of life, and afternoon you see the patient is dry. That happiness what we have seen in our clinic is immense. I think that really changes the quality of life. So Preetha, like this also, people use it, I think, like that's what you said, that Kegels, you do Kegels.
Yes.
So many people think that they have done their job if they have told the patient to do some exercise.
Right.
And this exercise also many times people do not make them understand. Today only I had a patient, we had a patient in the clinic. So I said, are you following the exercises which you? She says that, no, I don't want exercises. Some outside doctors have told her to do exercises, but she was saying that I don't do those exercises because my house is on 3rd floor. I have enough stairs. I do enough exercising. So we are here, we have to emphasize when we are talking to patient that are you doing exercises? This question is not enough. You have to ask what exercises particularly, whether she is doing pelvic floor related exercises or not, because it is a very loosely used term. So, and many times what I feel that every practitioner might not have luxury like us, that we work in a team in collaboration and we discuss things with everybody, and like everybody is so keen on the subject and dedicated. But every practitioner, every gynecologist I'm saying here, might not have this luxury, or maybe if some psychologist says and diagnoses. And sometimes when you tell the patient might be having other problems more, maybe she has depression. First, they want to deal with depression, but they do not understand that that might be linked to SUI.
Yes.
So, Preetha, can you tell, because whatever said and done, first line therapy for stress urinary incontinence is physiotherapy. Okay. Later only all other things start. So I want from you that if you can give some 2-3 steps for our practicing gynecologist
Yes.
or general practitioner or maybe a psychologist. See, it is not causing any harm. If 2-3 points that to do exercises like this.
Yes.
At least you try for 1 month, then we'll see. Maybe patient gets little 20%, 30% benefit by doing that, she might be little motivated to seek help from a
Yes.
gynecologist or a dedicated physiotherapist. So can you tell to our audience some 2-3 steps as a primary caretaker we should
So,
take?
first point I would say is about the breathing pattern. So, what happens is many of the times we have noticed that these patients do not have an altered. Actually, they have an altered breathing pattern. So, when you inhale, you need to actually have an expansion of abdomen, and when you exhale, it goes down. I mean, goes in fact. So, in these patients, what we have seen is usually a lot of associated stress or something. There's an altered breathing pattern altogether. So when we tell them exercises, we usually tell them to correct their breathing pattern first. So by inhaling, the abdomen should go out, and exhaling comes in, something like that. So that's something that you need to start from there. Then the second point will be, in case we find out that the strength is less and the tone is poor of your vaginal muscles when you do a palpation, and then the instructions that we usually give is. It's like lift and squeeze. So the muscles has to be when we just tell
So
them
just
to
squeezing is not enough. You have to
lift it and then
squeeze.
squeeze it.
Okay.
So the muscles just go inwards and upwards, and then you need to squeeze it. That's the
And how many
instruction.
times, Preetha, you should suggest as a primary modality
Yes,
of treatment that for how many times patient should do,
Yes.
and when she is holding it after squeezing and lifting it up, for how many seconds we should.
So usually, ma'am, again depends on your evaluation
Yes.
and the power and how much is the repetition, endurance, all that. But then I have read that many people tell them to do 200, 300,
Yes,
400. Whenever you
exactly.
switch off, you should do once. That's impossible actually. As a
Yes.
human being, it's
That's why I asked you this question, because I had seen the patient. She said, my doctor said do it 200 times. I cannot do it.
it is not possible as a human being as such. And then if you do it wrongly, then it's going to be the other way around. So usually we tell them to do about 4 to 5 times, 4 times in a day. So 3 to 4 times in a day, about 8 to 12 times repetitions. That's what we usually tell.
So they should dedicate a time for
Yes.
10 minutes, okay, in the morning, in the afternoon, in the
Right.
evening, and do it. And that squeeze and hold should they keep on increasing. Like I usually, I don't know whether right or
Yes.
wrong. And now I say that go to meet Preetha. She will tell you. But initially, when I used to tell that hold it for. You count it 1, 2, 3, 4, 5. Then increase the count.
Yes,
like
that's
that.
right, ma'am. We usually start with, again, after the evaluation, we come to know that she has about 3 seconds ability to hold correctly. Then you proceed it to a 5-second hold, and it's like 1, 2, not 1, 2, 3, like that. So you actually, tell the patient, count, ask them to also count. So we tell them that correctly, and then they can go up to 10 seconds.
Okay.
That's
Good enough.
That's good enough, yeah, actually, to start with. So that's how we usually tell them.
So in a 24-hour day, I think it is not 10 minutes every
Yes,
day. If you're 30 minutes, if you're
Yes.
dedicating to your own health,
Yes.
for your good thing, then I think it is very useful for those who are having SUI and those who are not having SUI
Yes,
also.
and
It's a
also,
good-
we also need to work on the fast twitch fiber. So this is about your the holding part. Now we have something called as fast contractions, wherein which, ma'am, you instruct them to contract for squeeze and lift to 1 second, then you relax for the next second. Again you contract. So they are fast contractions.
Okay.
So initially we did 5 seconds hold, whereas this time we are going to do 1
One
relax, 2 relax, because in SUI it's your fast fibers that need to work fast, because when you
See,
cough,
these small things are so important. No
Yes.
book has written it like that. I think this all comes by experience.
because when you cough, you need to have an immediate contraction
Fast.
that is required. So those muscles also needs to be trained. So hence we tell about 30 contractions are, if possible, they can do in one set kind of thing. So that's again another third exercise I would say. So breathing pattern correction, then you have your slow exercises, the holding ones,
exercises.
and then you have the fast twitch contraction. So that's something. But again, it all depends on your individual assessment, and we usually tell them not to squeeze in the hip adductors, to as a part of exercise. So that usually doesn't work because you need to also strengthen your abdominal muscles along with your pelvic floor. That's also very important. So though that goes in an advanced stage, so you need to activate the abdominal muscles along with pelvic floor. That's also equally important. But I would say that if there's a possibility that they hold their breath when they do these exercises, you can always tell them to take a deep breath, and as you exhale, let them do these exercises. So that way you also have an abdominal contraction and your pelvic floor also contracts.
So very good. That's what, if you have any point to add, what I learned today, that what message I would like to give, that we have to ask patients. And if somebody is having that, like putting all that courage and telling you, never ignore that patient, because that message goes to 5 more people, maybe that this is normal, nobody is going to listen to you. It is a very debilitating condition, and it is progressive. If we can treat it in early, just with physiotherapy, we can take care of that. But when it becomes severe, maybe we need a surgical correction also. That is extra. Then we can prevent that severity by not do it, isn't it? So I think asking patient about this problem as a part of your routine examination, whether the patient comes for a psychological complaint or some urinary complaint or some other related complaints, I think it's very important for them to ask them, because maybe they have told it to many people and nobody has given a thought to it. And when you treat it, the quality of life actually improves drastically. And patients are very happy when we have treated. Like the smile only is different. Okay. And we have to also understand that the psychological component is so much, because many patients have less problem if you grade it into severe, but they are so psychologically disturbed with that. So you cannot say that only severe problem needs one particular kind of treatment. Somehow you have to do the holistic treatment for the patient, depending on every patient is not. Some people might not take it so badly. Some people who are like maybe a young
very
patient,
sensitive patient,
very sensitive patient, maybe a young patient, newly married, she's or married and having sexual relations, difficulty during sexual relationship, she is having a moderate kind of SUI, as compared to that patient who is 60 years, who is not sexually active, who is happy with her children, grandchildren, not that much. So it depends how patients are taking their problems. So we cannot say that you are not having problem. And I think we learned a very important thing today, and that whosoever, if a patient complains, you don't wait her, don't make her wait, and don't say that no, you have to go to a city to get your physiotherapy checkup. And at least we can start when the patient knows that, when she realizes herself that there is 10% improvement with that, then she herself will feel like going to a physiotherapist for a proper training program. So I think whatever we can do, and I'm very happy that Preetha told us what all to do. So breathing, we have to breathing pattern. This all of us we can do. I think Sreelakshmi, you and me also.
This is something that it's very important for us also. When we are dealing with patients who have anxiety, when we teach abdominal breathing, this is the first step.
Okay.
Breathing correction, pattern correction. So abdomen should expand when you're inhaling, and it should go in when you're exhaling. So many times, if when I see that the patient has anxiety or stress, and I want to do abdominal breathing for the patient, it's given in a combined way. Anyway, ma'am's exercise also starts with the abdominal breathing. So I just have to tell them the significance of that breathing in the other aspects also. So it gets generalized in transferred in that way as well.
And it is such a simple thing.
Yes.
So many of us, we do not know about our own bodies. So
Yes.
I think small little things we are also learning, we are also teaching. That's how we grow.
Yes.
And if you have any experiences related to that, you are most welcome to share it with us. If you have any doubts, please drop your comment in the comment box below. And we'll keep on coming with such similar discussions. We have named this session especially as Experience Chat, where we all share our experiences. Thank you, Preetha. Thank you, Sreelakshmi, for being with me today.
Thank you so much.
Thank you,
ma'am.
ma'am.
Bye.